Welcome to the QI Bitesize series. This session is looking at data for improvement, both qualitative and quantitative data. I'm Sam Machin, the Improvement Facilitator at CLCH, and I'm part of a wider quality improvement team who are here to support all improvement in the organisation. The aim for this session is to identify the types of data that could inform improvement work and identify the merits in all of these different types of data. In terms of the objectives, it's important for us to recognise the different types of data available and when both may be appropriate, as well as having an overall awareness of the way in which quantitative and qualitative data can be collected in healthcare to inform improvement work. So initial reflections here, which may seem quite a simplistic statement, but is that we need to ensure the data answers what we need to know. There's no point collecting data that is unnecessary in terms of time constraints, but also the data we're collecting must be closely aligned to our improvement aims. So reflection is needed to think about, well, what do we need to know and what data is available for this? So a useful tip here could be to create a list of questions, improvement questions that is, and from this identify the data you think you may need from this. But how should we look at the data? As I've mentioned, the questions we're looking at are very important, but they're also important in the way we collect our data. They inform the data we'll be collecting. That's why transparency is so important. So in the first example here is intervention efficacy. So the example I'm giving here is a implementation of a medication safety scorecard. So myself and a team have created the scorecard. We want to know the impact of it. So we have a situation where we have data before the safety scorecard was popped in. So say that's data A, and data afterwards, so data B. Using this data, we can compare what's the effect on medication errors, where that may be prescription errors, dispensing errors, administration errors. We're able to use the data before and after to identify if our intervention has been a success or has created any impact. In terms of process mapping, if we were interested in understanding the time from a patient presenting to the emergency department to being admitted to a ward, for example, against an organisational aim or a national aim, we may want to process map this, and we may need data to understand the time differences. So we may look back over a period of 3-4 months, and we may look at the time either in minutes or hours, and we may use information aggregated, so the average time or the median time. And this is why we need numerical data to inform the time. But then we also may be looking at patient or staff experiences. So for the example I've given here is increasing patient satisfaction with remote monitoring. So to understand how remote monitoring is being engaged with by patients, we may collect some data in terms of their experiences, which really lends itself to a narrative data set. We want to understand how they're reacting to this type of care and the barriers and facilitators. But in terms of how we look at the data as well, it's really important for us to be aware of the data that we have available first. So data collection itself in terms of improvement work can be quite time consuming. So if there is data that already exists or is already routinely collected, then this really should be the first port of call. So where do we get this data from? So as I said, there are two different types of data. There is pre-existing data and generated data. So pre-existing data really refers to kind of data that's already existing in the organisation or already routinely collected. So you've got historical audit data. For example, if I'm looking to do an improvement project on the rate of falls, it may be that there is a bedside audit done once a month, and that has been going on for 2-3 years. That's a good amount of information, a great resource that can inform either the data we collect or we actually use this data within our improvement work. Clinical information systems will hold descriptive information about things like unit of clinic visits, patient demographics, etc. So if you have access to that, that's a good way of collecting data as well. Outcome measures that may be routinely collected. So for example, patient-reported outcome measures for a particular service. Payment and reimbursement data, so the quality outcome framework will adhere to data that's collected routinely. If there's access to that, that would be very helpful. Or local records. So if you're doing a project and you think that in the division or within the trust there may be someone that's done something similar, go and speak to them and see if they have any data collection methods that you can either copy, learn from, or kind of iterate. And generated data really refers to new information that you're generating. So it doesn't already exist, and you're using data collection methods to generate this information. So that could be you creating a new audit or using new data collection methods. So for example, surveys, interview or focus groups. So there really should be a data collection plan when we're talking about data improvement and whether or not we're getting qualitative or quantitative data. As I said, we need to talk about what do we already have. So is the data complete? Is it accurate and is it relevant? So I guess there may be a massive data set already within your organisation that you think could be useful, but if it's not complete or it's not actually talking about the thing that you want to be talking about and it's not relevant, then actually that may mean you need to go and collect different data. If that's the case, what do we need to collect it? Do we need permission to access the data sets we have, or do we need permission to collect more information? Are there existing survey tools that either would be in a local or trust level? And how will we collect it? Is it online, over the phone, or in person? With these three different examples affecting the way in which we can collect information. For example, surveys online may yield a lower success rate, whereas calling may have a difference in terms of who responds. So talking about qualitative and quantitative data, so it's important to identify that within improvement work, sometimes these can be seen as juxtaposing types of data collections that you can't use together, two conflicting methodologies. That's not the case at all. Within improvement work, improvement work really yields great benefit when these two types of data are combined together. But just for the ease of explaining the two different types, I'll look at them separately, but then give examples of where they both could be used together. So quantitative data is really dealing with numbers, things that can be measured, and the quantity of things. It's addressing questions such as how much. The given example here would be what's the compliance rate with online education classes. So we're interested in seeing how many people were invited to these education classes and how many people attended. Very simple descriptive information. So the information is descriptive. Examples could be events such as death, GP visits, clinic visits, individual characteristics, so patient demographics, weight, blood pressure, blood glucose, so we can track those over time, or service attributes, so cost or waiting times. Qualitative data, on the other hand, is looking at descriptions, engagement and experiences. It's addressing the question why. So to give an example of the same concept but looking with qualitative data, how do patients engage with online education classes? So we know that they're being invited to these education classes, but we want to understand the barriers and the facilitators to these patients joining these online education classes. Information normally comes from multiple perspectives, so maybe from staff, patients, service users, to look at these barriers and facilitators. They're looking for kind of narrative viewpoints, but they also can expand on descriptive quantitative data. So with the example I've just given, the whole improvement work could be improving engagement with online education classes. So the first port of call is to understand how many people are going and how many people are not going. What is the kind of non-compliance rates? But why is that? Why is it rate so high or so low? And what can we learn from narrative information from patients? This is a really good example of how you can compare both quantitative data and qualitative data and how they can be very complementary to one another. So how to collect quantitative data? So I've given two examples here. We've got surveys and longitudinal data. So surveys, very simple, set questions, normally a Likert scale. So for example, 1 to 10. They're very easy to aggregate with platforms like SurveyMonkey. Longitudinal data is talking about time series data. So we're measuring across a defined period. So the example here is how many pressure ulcers has ward A developed in a 12-month period and how many are acquired. So we can look at 12 months of data and we can glean that information. Qualitative data, on the other hand, there are three different examples here. We've got interviews, focus groups and observations. So interviews are one-on-one interactions with an individual to explore a narrative around a question. So if I want to understand engagement from staff, I may use an interview technique, one-on-one, and it will have a very good narrative engagement in terms of their experiences with a particular intervention. Focus groups are organised discussions with groups of individuals. So if you want to understand groups engagement, understanding narratives, you can create one of these. So the example I've given here is barriers to online education courses for patients with type 1 diabetes. And finally, observations. So these are logging of events. They're recorded description of events. So They're useful in terms of looking at what's said and what's done, so a compliance of standards for staff, doing double checking for controlled drugs. Examples of observation could be observing how many people are doing that safety check against a predefined target or something that you were hoping to see. So next steps for you would be to watch the rest of the Measurement for Improvement series. For example, we have sessions on the presentation of data, time series data via SPC,